I'm honored to be regarded as one of the best surgeons. I didn't know that. And you're very welcome to join the surgical team, of course. And I welcome everyone who is on this forum today. Thank you very much for the opportunity you've given me to be able to present our topic today. And our topic today is prostate cancer. Can I hear, please, if you can hear me very well?
Doc, you are audible enough. We can hear you. And the slides are shared.
Okay. Can we go to the beginning slide, please? So my name is Dr. Josephine Namugenyi. As already been stated, I'm from Soroti Regional Referral, but I'm also a fellow under the co-sector. So I'm doing my fellowship in urology. The slides are not moving from my side. Okay, I'm told we have a range of professionals on this forum. So I'm going to introduce the topic by starting with what we are dealing with. We are dealing with the prostate as an organ. It is a walnut-sized organ, which is contributing to the reproductive organ. It is only found in male. And it's located behind the base of the penis and in front of the rectum, and it's below the bladder. So because of its location being below the bladder, the urethra, as it starts off, comes through it, and then it continues downwards. Its primary function really is to produce a fluid that contributes to the semen, and the purpose of that fluid is really to nourish the sperms. Next slide. Okay, I thought it would be important for us to know about the different anatomical parts of the prostate. The prostate is a small organ, as we have said. Anatomically, it has 3 lobes, that is 2 lateral lobes and a median lobe. But also physiologically, it has 3 major zones. That is the peripheral zone, the central zone, and the transitional zone. But it also has a small area, which is called the anterior fibromuscular stroma. It is comprised of cells, that is the stromal, the glandular, and the smooth muscle cells. I don't know why the slides here are not very visible. So the prostate, because it is very important for the male reproductive organ. It contributes a lot, but it also, being an organ, it can be affected by disease. It can be affected by both benign and malignant disease. So some of the benign diseases that can affect the prostate are, you've heard of benign prostate enlargement, that is whereby as the man keeps growing, the prostate also enlarges. That is as a result of different effects. But age is one of the factors. Then there is the other, the prostatic enlargement also can be confirmed histologically. That's where you get a diagnosis of benign prostatic hyperplasia. This is the same issue, only that one is clinical diagnosis, the other one is a histological diagnosis. And that is not our topic today. The other benign disease is prostatitis, which can be either acute or chronic. The malignant disease that usually affects the prostate is prostate cancer, and that is our topic today. Next slide. So I'm sure the medics are aware what prostate cancer is. So it is for the purpose of the non-medic, I'm going to define what prostate cancer is. So it is a malignant tumor that can affect the prostate, the gland which we have already defined. So as far as the prostate is concerned, it is attacked, that there are different types of cancers. So the majority of them is over 95% is adenocarcinoma of the prostate, but there are also different other types which are non-adenocarcinoma, which comprise of less than 5%. And I have listed them down. You'll go through them, the people who are interested in them. Next slide. So we are going to look at the epidemiology of prostate cancer. It is the most common cancer among men in Africa. However, the developed world, it is regarded as the second, next only to skin cancer. And in other literature, it is next to, it is third, and next only to pulmonary and skin cancer. In sub-Saharan Africa, we have a higher burden, with Uganda and Zimbabwe having the highest burden within sub-Saharan Africa. In Uganda, according to the literature from UCI, Uganda Cancer Institute, the burden, the incidence of prostate cancer ranges between 37.
Me, I started in 2018.
Hello.
Yes, Doc, you go on. Please, colleagues, when you join, please unmute. Dr. Josephine, continue.
So I was talking about the incidence of prostate cancer in Uganda. It ranges between 37.1 to 65. Some literatures have 37, others have within that range per 100 cases. This is, of course, far below the one for the one found in the Black American patients, which is stated to be around 172 per 100,000 cases. So although it's below, but the burden of prostate cancer is quite high for us. In Uganda and Zimbabwe, we have the highest within the sub-Saharan Africa. So what are the risk factors that predispose one to prostate cancer? One of the major factors is age. So as one ages, as far as when you are a male, as you age, you can't run away from prostate cancer. So it's one of the risk factors that affect more than 70% of cases occur in men who are older than 65 years of age. The other risk factor is the race. So black people or African race is regarded as being one of the factors. In Black men, prostate cancer is also found to be more aggressive, and commonly patients present late. So they present when it has already advanced. Having a family history of prostate cancer or breast cancer is another predisposing factor. So when you have a first degree relative, either father or a brother, the chances of you having prostate cancer are very high. But also having familial genes like the BRCA1 and BRCA2 for breast cancer also predisposes one to get to having prostate cancer. Kindly, I'm getting feedback. Obesity is another risk factor. So it was found that, according to the literature, it was found that men who are obese usually are difficult to treat. So they have higher recurrences, and also their prostate cancer is more aggressive. There is also literature that talks about dietary as being one of the significant factors. And one of the things that was raised, that an increase in vitamin D may increase the risk of developing prostate cancer. But it's also greater in men who consume a lot of amounts of excessive fat, animal fat. So one of the things whereby what we can do to prevent or to reduce prostate cancer or to reduce the risk of prostate cancer is looking at our diet. Next slide. So apart from what we've raised, there are also myths that people think are risk factors, but in actual sense they aren't. I thought this is important to put, considering the fact that we have members who are non-medic. So one of the myths that I believe that if one is sexual activity, the more one has sexual activity, the more risk, the higher the risk of prostate cancer. This was found to be a myth. In fact, studies have shown that men who report more frequent ejaculations actually have a lower risk of developing prostate cancer. The other thing is vasectomy. Most people believe that having a vasectomy will predispose you to getting prostate cancer, and studies have shown that this is not true. Medications, there are studies that have, there are beliefs that have been thinking that taking certain drugs, for example, aspirin, may reduce the risk of prostate cancer. However, most studies have shown that this may not be true. Although there are some drugs like finasteride, when you give it to patients, some studies show that the progression of cancer to malignant, to advanced stage may reduce, but it does not protect from having prostate cancer. Also, finasteride has a disadvantage in that it reduces the PSA. That does not mean that the prostate cancer has gone away. It only means that when you're diagnosing the patient, you have to double the PSA value that you get. Next slide. So we are going to briefly look at the natural history. This natural history is not really academic. It's more of to understand what really happened. So initially, the prostate, the cancer starts as small lumps of cancer cells that remain confined onto the prostate. And in this case, you may not be able to, the malignant changes may not be seen, but it's just a dysplasia that happens within the cells. So it starts as a dysplasia. And in this case, it is known as carcinoma in situ or prostatic intraepithelial neoplasia. So with time, this may progress. The pin, that is prostatic intraepithelial neoplasia, may be either low grade or high grade. So the low grade does not have a high risk of developing prostate cancer, but the high grade pin has been found to progress into prostate cancer. So usually when you get a patient with the histological diagnosis of high grade pin, you need to follow them up in that to make sure that they don't end up getting advanced cancer, so that you need to diagnose them when the cancer is still localized within the prostate, because that one at least it is treatable. So over time, these cells may multiply and spread to the surrounding prostate tissue, forming now the tumor. Eventually, the tumor may grow large enough and it can overgrow beyond the capsule and now invade into the organs surrounding the prostate. And these may include the seminal vesicles, the rectum, or the lymph node. Such type of cancer is known as locally advanced prostate cancer. Now, if it grows further or if it spreads, and in the following slides, you'll see the routes through which it spreads. It then can spread to other distant organs, including bones, the lungs, the liver, and this one, we call it metastatic prostate cancer. We shall be referring to that. That's why I thought it is good to bring it early enough. So in my next slide, that's where I talked about the cancer may spread through either direct extension or through the lymphatic system or through blood. And through those routes, it can reach the distant parts of the body. Next. So how does prostate cancer present? I think that should be my next slide. So for early prostate cancer, in its early stages, it may be asymptomatic. This is why it is very important to do screening. We've been, you'll hear, I was surprised that I was requested to do this presentation in this month of March. Usually this presentation is requested for during the month of November because we know that is the prostate cancer month and we call it Movember. So I was taken aback when I was requested to present this that topic now. So back to what we were saying, early presentation may be asymptomatic. So the patient may not actually have any symptoms. But for those who have been, who have the awareness, if awareness has been created to them, they are encouraged to come, especially men or above 40, 45, especially in our setting, whereby we've heard that, we've known that being Black, being African ethnic, you're more predisposed to getting prostate cancer. So for locally advanced prostate cancer, which I've already defined above, these patients may present with symptoms of blood outlet obstruction with lower urinary tract symptoms. So they may have symptoms like intermittency, frequency, sometimes urinary retention. Sometimes they may they may have decreased force of urinary stream. Sometimes they may see blood. This is because the prostate has now gone to the bladder, so it will irritate the bladder. So they may see the bladder or the urethra. So they may see blood in semen or in urine, that is hematuria or hematospermia. Sometimes they may present with painful sperm ejaculation, dysuria, or dribbling. Dribbling means that they get drops of urine even when they are not feeling like urinating or following urination. Then the metastatic prostate cancer may present with other symptoms, which commonly the prostate cancer metastasizes to the or spread to the bones, and in this case, the patient may present with bone
Dr. Josephine, are you there?
Yes,
Dr.
please.
Josephine.
Can you hear me?
We had lost you the last 1 minute.
No, we are hearing her.
Okay, I'm sorry.
We are hearing her.
You can go on.
Okay. So I talked about early presentation of prostate cancer, which may be asymptomatic. Then the locally advanced, which may present with lower urinary tract symptoms as a result of especially irritative symptoms. Then the metastatic prostate cancer, which may present with different symptoms depending on where it has spread. But commonly it spreads to the bone, like I was saying, and these patients may present with unremitting bone pains. Sometimes they may present with pathological fractures or spinal compressions or backache. So that is the common presentation of advanced prostate cancer. But sometimes they may present with other symptoms, including anemia, weight loss, general body weakness, renal failure. So these are mostly paraneoplastic symptoms. Next. So how do we evaluate these patients? So like any other patient, we need to start with the history taking. We take the patient's history, their family history, like we've had. Family history is very important. the history of their presenting complaints will help you know at which stage the patient has presented. Hello? I see that the slides are going off.
No, you continue. We are just switching the person sharing.
Okay.
But you can
So I was
proceed.
saying, history and physical exam are very important. So on physical exam, usually you can do a general physical exam because like we've had, many organs may be affected. But more specifically, please do not forget to do a digital rectal exam, because this is going to help you to diagnose the state of the prostate. And with the digital rectal exam, it helps you to know, is it a suspicious prostate? Is it an advanced prostate cancer which has penetrated, penetrated into the structures that are surrounding the prostate? So you're able to feel with your finger to tell one, the size, the consistency, the presence of nodules, and any other information that you may want. The other thing is the PSA, the prostate specific antigen, which is a lab request. Next. So like we've said, you do a digital rectal exam, you do a PSA, but the diagnosis of prostate cancer is confirmed by doing a prostatic biopsy. Am I far or you can hear me well?
We are hearing you.
Okay. So the diagnosis of prostate cancer can be confirmed by a biopsy. What do I mean by a biopsy? For non-medics, a biopsy is whereby we take off a piece of the prostate. We go through the rectum as the way you do a digital rectal exam, and I'll have a slide to show that. And then using a needle, you take off a small piece of meat of that biopsy. And this is sent to the laboratory, and it is looked at under the microscope to see whether we have any cancerous cells or not. So one of the diagnostic tools that we use is the transrectal ultrasound. Although in the literature, the old literature, the digital rectal exam is an important clinical exam, but literature today shows that for you to be really sure, it's better to use a transrectal ultrasound scan. This does not mean that you do not need to do a digital rectal exam. The digital rectal exam is part of your clinical exam. But then as you start to investigate, one of the things that are very important in getting, especially the small cancers, the cancers which are not easily palpable, is using a transrectal ultrasound scan. Then we have other imaging tools. Next slide. So that the other imaging tools will really help you to see if there is any metastasis to either the structures that surround the ultrasound, I mean the prostate, or if there is distal meets, for example, to the bones, to the liver. So some of the other diagnostic tools we use, apart from the transrectal ultrasound scan, whose image I've put on that slide, for those who do not know. So the probe of the scan is actually put through the rectum, the way you put your index finger. In this case, it is the probe, and it goes direct to the prostate. So it can easily visualize it, and it can give you the information that you need. So like I was saying, the other imaging modalities, especially for low resource areas, for me, I work in a low resource area. So a lumbosacral X-ray usually helps us. but that may not give us all the information. So sometimes we need to request for a pelvic CT or a pelvic MRI to tell us more, to give us more information. Also, when we suspect the patient has come and they are met to the bones, we may request for a bone scan. Sorry, I did not include it here. Next. So I thought it would be important to drill more on the prostate surface antigen. So this is a protein that is produced by the prostate, and it is found mostly in semen. However, there are small amounts that are also thrown into the bloodstream. So this test usually when there is any disease to the prostate, the prostate surface antigen protein may be raised. So it is not only for prostate cancer that it raises, but there are also other causes, that other disorders that can lead to its increase. Some of them include the genitourinary infection, for example, UTI. It can lead to elevation of the PSA. Prostatitis can lead to elevation of the PSA. But even ejaculation, that activity of ejaculation, because it leads the prostate to squeeze, it squeezes. So because of that, it ends up, the PSA may be elevated. Then prostatic trauma of any kind, either after catheterization or any instrumentation like dilatation or prostatic massage or the prostatic biopsy itself, or any activity, sports activity like cycling, all these can lead to an elevated PSA. So what does that mean? It means if you get a patient with just one single value of elevated PSA, this means you cannot rely on it for you to say the patient has prostate cancer. So there are other things that you have to take into consideration. Like we said, the history is very important. The presenting complaints of the patient, how the patient presents to you, all that is important. So, and you can do other values depending on how the patient has presented to you. So the other terms regarding prostate, there is what we call prostate velocity. This is the rate of the rise of PSA over time. So the faster it increases, the more the risk of prostate cancer. So you can utilize that. Second, there is what we call prostate density. This is the PSA, amount of PSA per volume of the prostate. So you get the total PSA that you've gotten over the volume of the prostate, then you get the prostate volume. So the higher the prostate density, the more the risk of the prostate cancer. Then there is what we call free PSA. PSA in itself, there is one which is bound, and it's bound on some protein, on some substances within blood. And then there is one which is free bound. So the free bound prostate cancer may not, prostate surface antigen may not be affected by things like infection, by trauma. So it will be, for it will not elevate. So in case you get, there is a I'm getting feedback.
We have unmuted him. Please continue.
So can we go to the next slide? So remember, we say that what the major two tools is the PSA and then the digital rectal exam. So on this slide, really, I simply wanted to define what a digital rectal exam. And this is whereby when a patient visits the doctor will insert a gloved finger, which is well lubricated, into the rectum, through the anus, into the rectum, and try to feel for the prostate. Some of the things that we feel for is the consistency of the prostate. If there are any nodules, the size, although you may estimate the size, but of course the transrectal ultrasound scan may be the one to give you the exact size. We've seen here commonly, we get the prostatic volume through an abdominal pelvic ultrasound scan, but the one which is more accurate will be the transrectal ultrasound scan. So a combination of an elevated PSA and a suspicious digital rectal exam may drive you or inform you to send the patient for a prostatic biopsy. Next. So prostate cancer can be described using the staging mechanism, the staging method. So staging is a way to describe the cancer such that you know how far it has gone, the extent of its spread. So staging is used to determine the patient's prognosis. So if it is, for example, a T1, or if it's a T4, those are two different stages. And we commonly use the staging system of the TNM system. In this TNM, we consider that the tumor size, which we regard as the T, the spread to the lymph nodes, which is the N, and then whether the cancer has spread distant to the distant organs. That is the what we call metastasis. And we've already talked about the organs that it can get affected. That is to the bones, to the liver, to the lung, etc. Next slide. So on this slide, I try to indicate the TNM staging. Of course, T0 is when there is no evidence of the primary tumor. There is no evidence of the cancer. Then T1, it is clinically inapparent. What do we mean? It means that even when you do your digital rectal exam, you may not feel the tumor clinically. So this is where we say that you can use other modalities of investigation to help you to know at what stage or whether there is a tumor or not. And T1 is it is subdivided into TA, T1A, T1B, and T1C. All these are clinically inapparent. So for T1A and T1B, we get these tissue. We get this from prostatic tissues that have been removed by transurethral resection of the prostate, especially when a patient has BPH or benign prostatic hyperplasia. They may be having obstructive symptoms, and so they may be indicated to get treatment. So once they go for a TURP, those tissues, we usually do not throw them away. We usually send them for histology. So for T1A, sorry, is whereby you have less than 5% of the tissues which have the tumor. If you have more than 5% of the tissues, then it is T1B. T1C is the one which you get through your prostatic biopsy. We send the patient to do a prostatic biopsy, and the tissue that comes out tells us that the patient has prostate cancer. So that means that cancer is still localized. Then T2 is when the tumor is palpable, but it is confined only to the prostate. and I try to put the pictures. So in this case, you'll feel the prostate is suspicious, and you send the patient, or you do a prostatic biopsy. And it is also divided into three. There is, into two. There is T2A and T2B. T2A is when only less than a half of one lobe is affected. And then T2B is when there is more than a half of the lobe, but just that one lobe is affected. Once the cancer involves both lobes, then it is T2C. T3, I thought I'd put all the T's here. T3 is when the tumor, T3 is when the tumor involved is now has gone into the capsule, but it does not, and it can only infiltrate into the structures that are next to the prostate, that is into the seminal vesicles, into the rectum. Once it goes beyond, then it becomes a T4. Next. So then we talk about the node, involvement of the lymph nodes. So if there is NX, that is lymph node involvement cannot be assessed. N0, when the lymph nodes, there is no positive regional lymph nodes. Usually during surgery, for example, when you use an MRI or a CT scan, it can tell you whether there is lymph node involvement. But also at surgery, you might take off, when you do radical prostatectomy, you can do lymph node dissection. So in this case, you take out the lymph nodes and then you send them for histology. Once there is not a positive regional lymph node, that is an N0. N1 is where there is invasion of the regional lymph nodes. Then the METs, when there is what we call MX, that is distant metastasis, cannot be identified. Then M0, there is no distant metastasis. Then M1, there is distant metastasis, METs to the rest of the organs which we talked about above. Next. So one of the factors that we prognostic factors that we talk about or we consider in prostate cancer management is the Gleason score. And what is the Gleason score? So the Gleason score considers structural patterns of the cells of the prostate. And these ones are divided, they are divided into from 1 to 5. So when you're scoring the Gleason score, you get the most abundant or the most changed cells plus the next abundant affected cells. You put that you get a sum of that, and that will be your score. For example, if you look at on the left side, you can see that we have a Gleason 6 to a Gleason 10. So a Gleason 6 can be either 3 plus 3. Okay. Or a Gleason 7 can be a 3 plus 4 or a 4 plus 3. Now you'll see that we grade them differently. So when Gleason scoring was done, we were getting from Gleason 6 to Gleason 10. But then the International Society of Urological Pathology came up with a grading. That is, they graded these Gleason scores from 1 to 5. And the Gleason 6, less than 6, was regarded as 1. So Gleason 7, which starts with a small, the most abundant being less changed, plus the 4, which is more changed, which is secondary, was group 2, grade 2. And it went on and on. So we have grades 1 to 5. The same grading was taken up by the World Health Organization. So currently, we use that ASOP or World Health Organization grading plus the Gleason score. Next. So in the treatment, I think in this slide we are starting the treatment. How do we manage patients of prostate cancer? For patients with localized prostate cancer, and they present as the stages above, they have a higher potential for cure, so their treatment will be different. Then with those with regional metastases, the cancer has spread to the regional lymph nodes. And then those with METs, they will also be treated differently. And these ones are usually incurable. We just have to do palliative management. Next. So using the Gleason score, the TNM staging, and the PSA, we came, D'Amico had to come up with the risk stratification. There are different risk stratifications, by the way, for prostate cancer. This is a disease that has affected men so much over time, and it has been well studied. There's so much of studies that have been done, and there's so much of risk stratifications that have also been done. So these patients are grouped into risk, the low risk, intermediate risk, and high risk. And with this, you see that the tumor, which is localized just to the prostate, they are found to be low risk with a PSA of less than 10. Then those which have gone to either to the other lobe with a Gleason of 7 and a PSA between 10 to 20 is found to be intermediate. Then those which are beyond have with a Gleason of 8 and above with a PSA of more than 20 have found to be high risk. So either of these can give you the risk, the risk stratification of that particular patient. Next. So I've already talked about that. We consider prognostic factors that we consider is the Gleason score, the tumor stage, and the baseline PSA, but also the percentage of the biopsy score may be important. Next. So we have different treatment modalities. This presentation was, the time given to me was a bit short for me to include all the treatment modalities. So, but most of the treatment modalities I've tried to show them in these slides. We may not see all of them, but I tried to highlight those that I thought are important, especially in our setting. And although when you go to a urologist, we may not start by telling you about lifestyle modifications, but this is part and parcel of prostate management. I am getting feedback. So the other treatment modality is deferred treatment, whereby you try to simply either follow up a patient and see how they do. This is because you want to reduce on the toxicity of the treatment, or you think the patient is not fit for surgery, or I mean for treatment, or you think that following them up may not be as, giving them treatment may not be as important as following them up. So you start by following them up. That is what we call deferred treatment. And it's divided into watchful waiting and active surveillance. And we shall see the difference. Then there is surgical management, whereby you do radical prostatectomy. This is the gold standard for curable disease. The other mode of treatment is radiation therapy, which can be divided into external beam radiation therapy or brachytherapy. We commonly here, I think we have the external beam radiation therapy. I'm not sure if we do have brachytherapy yet. The other treatment is hormonal therapy, which can be divided into androgen deprivation, estrogen, and other therapies, and we shall look at them. The other thing is focal therapy for disease which is localized. So we go and we just attack where the tumor is. Other therapies include thermal ablation, cryotherapy, HIFU. HIFU is high intensity focal ultrasound therapy. I'm not sure if we have it yet. And also there is laser ablation. We do not have. Those ones which I put on the right side, I think we may not have them here. But they are all treatments for prostate cancer. Next. So when you talk about lifestyle modifications, what do we mean? In this case, we mean what the patient has been doing. What have they been doing? How has their lifestyle been? So you can, if they've not been feeding well, you can tell them about the kind of food that they can take. In dietary, usually we encourage vegetable dietary. We encourage low-fat dietary because red meat and dairy products have been found to be predisposed to have a negative effect. Then vitamins are encouraged, but although there are some vitamins that have been found to have a negative effect, like vitamin D, but we encourage patients to, especially in our setting whereby the foods are readily available, you encourage them to have their fruits and vegetables into their diet. Encourage the patients not to have a sedentary kind of lifestyle. Let them exercise, let them be active. They do not have really to go to the gym because some of them may not afford that, but let them be active. If you get a patient who is a smoker, discourage them from smoking and also take alcohol in moderation. Obesity was found to be one of the predisposing factors or to have a negative effect on the healing of prostate cancer, on the negative, predisposing someone to have a negative advancement, progression to a worse stage. So managing the patient's BMI is important, and it's very, very important to counsel this patient as far as that is concerned. That is as far as lifestyle modifications are concerned. Next. So what do we mean by the deferred treatment? And here I wanted to talk about the watchful waiting. Most of the time when you read some literatures, especially to mistake the two, they confuse the two. So watchful waiting is really observation. He's monitoring the patient until they develop symptoms that may require palliative treatment. And this is usually for patients who have a life expectancy of less than 10 years and they are of low grade. Their cancer is of low grade, with a Gleason score between 2 to 6. Remember, that was low grade. Then active surveillance. This is delayed treatment till there is evidence that the cancer is progressing. It involves routine follow-up and testing of the patient with the intent to provide curative treatment once you see that there is need. So here that the strategy is to delay the treatment that might not be necessary. You might give overtreat. You know, one of the cons of screening, especially with the studies that have been done in the West, they usually discourage screening because they say that there is overtreatment. I think in our setting, we've not been overtreating because you find that most of our patients come actually late. They come in advanced stage. So for you, in order not to overtreat the patient, you do active surveillance. And it is also indicated for patients who are of low volume cancer. That means it is localized. And also intermediate grade, you can also give them this kind of treatment. But once you identify that there's progression and there is need for treatment, you initiate the patient on treatment. Next. So on this slide, I simply wanted to indicate to you that the difference between active surveillance and watchful waiting. Initially, also, I used to confuse the two. So the treatment, what is its purpose? The purpose for active surveillance is actually curative, whereas watchful waiting is palliative. Remember, these are patients, it's given to patients whose life expectancy is less than 10 years. So you do not want to put this patient to go through a lot of suffering with the side effects of the treatment. Then the need for follow-up. In active surveillance, it is scheduled. You know that the patient will come after 3 months, we have to repeat either a PSA or a digital rectal exam, or after 6 months, we need to rebiopsy. So there is a schedule to follow. Whereas in watchful waiting, it is patient specific, depends on how a patient presents. Then assessment tools or markers, you can in active surveillance, you use a digital rectal exam, PSA, you can rebiopsy, but in watchful waiting, there is no definition on what you really need to use. It is upon the physician to decide on what to use. Then life expectancy, like we said, in active surveillance, it has to be more than 10 years, and in watchful waiting, life expectancy of less than 10 years. We've talked about the aim, to minimize treatment-related toxicity without compromise to survival. So you make sure that the patient survival is important. Whereas in watchful waiting, you minimize treatment, which is treatment toxicity, knowing very well that the patient is not going to benefit much from it. Next. Next slide, please. The slides have not moved. Okay, so one of the treatment modalities that we looked at, we've looked at the lifestyle modification. We've looked at the deferred treatment.
I think, Doc, you can proceed as Claire tries to move the slide.
Once you decide to treat, you decide, is it localized kind of cancer, or is it locally advanced or metastasized cancer? For localized cancer, the gold standard of treatment is radical prostatectomy. But the patient should be fit for that, so the patient should be healthy enough. Their life expectancy should be at least 10 years. The tumor should be deemed resectable, which means it should be a localized tumor to the prostate. And then the age is also of importance, and patient fitness. There are patients who are of less than in their 60s, but they are weak actually. And then there are patients who are 75 and they are actually very fit. So age is a factor, but also you need to assess the patient for fitness. Next. So radical prostatectomy really involves the removal of the entire prostate, the ampulla, and also the seminal vesicles. And it's because of the extent of the trauma as you do this surgery, it also has advantages and disadvantages. But before I go to the disadvantages and advantages, the approaches through which it is done are also important. I did not include them here, but it can be done through open radical prostatectomy, and that is what we commonly do here in Uganda in the different hospitals. There is laparoscopic, which is pure laparoscopic surgery, but also there is laparoscopic robotic guided. And it can be done through the transabdominal approach, but there is also in literature, I've seen transperineal also, although I've never seen it. So what are the disadvantages? I mean, the advantages of radical prostatectomy. Like I said, it is the gold standard for localized tumor. So the possibility of cure, there is minimum collateral damage when done by a skilled team. Treatment failure is easily identified because you take out the tumor, you send it for histology, and they'll tell you if the tumor margins are negative, that is free of cancer, or they are positive. Then they are potentially curative. And if there is a need to get adjuvant radiotherapy, you can easily start it early enough. Now, but it also has disadvantages. One, it has a long hospitalization stay and recovery period. The possibility of incomplete tissue resection is also there, but also it is associated with complications. Some of the complications associated with radical prostatectomy is bleeding. Later, it may be complicated with erectile dysfunction in 20 to 100% of cases. It may be complicated by urinary incontinence in 4 to 70% of cases. This can be prevented by starting muscle flow exercises pre-operatively. The other thing is stricture formation, because the prostate is taken out, and as you take it out, there is trauma to the urethra. So the healing may form with a scar, which can cause a stricture, hence preventing urine flow freely. The other complication, which I did not include here, is mortality. It also has a mortality, but although with improvement in literature, I mean in technology and literature currently shows just less than 1% of mortality, which is very good. I'm not sure if there are any studies that have been done in Uganda as far as radical prostatectomy is concerned. And we don't know our mortality percentage level. Next. So the other treatment modality is hormonal therapy. We know that, although I did not mention it at the beginning, prostate cancer or the prostate really survives so much on hormones. So it depends on testosterone, which is transformed into dihydrotestosterone, and this contributes to the prostate growth, but also the growth of especially the cancerous cells. They depend a lot on the dihydrotestosterone. It is more potent than the testosterone itself. So because of this, hormonal therapy, by hormonal therapy, I mean the hormones that can counteract the effect of of dihydrotestosterone are very important in this case. So these are indicated in clinical stage T1 to T3B and in other selected cases of T4. So it's not only to localized cancer, but also it can be indicated for patients who are intermediate risk and a selected few of high risk patients. Then patients with a Gleason score from 2 to the low, from the least to the highest. Next. Oh, sorry, before you go, there are 4 types of hormonal therapies. I thought we would talk about a bit about them. There is, you've seen us doing ochiectomy, the subcapsular ochiectomy. Then there is medical castration, where we use luteinizing hormone. Then we can, there is inhibition androgen synthesis, where we use things like ketoconazole. And also there is where we use anti-androgens. Those drugs that can work against, they compete for the androgen receptors with the dihydrotestosterone. So they work better by competing for that, for that. Next. Next slide, please. So that's the hormonal therapy also has side effects. With the castration, whereby you can do medical castration or surgical castration. For surgical castration, like I said, we simply do ochiectomy or orchidectomy. For medical, we use drugs to counteract the effect of the dihydrotestosterone, or to block it, that is. So in castration therapy, you have complications like loss of libido because the testosterone is not there, erectile dysfunction. Patient may have hot flashes, just like a menopausal person. They may develop gynecomastia or breast pains. They may have decreased bone mineral density. They may develop osteoporosis, muscle wasting, and also sometimes anemia and cognitive issues. For those who are on estrogen therapy, they may have cardiovascular issues like MI, cardiac failure, DVT, pulmonary embolism. Those are side effects of estrogen. Then for the luteinizing hormone releasing hormone agonists, they may have flare phenomenon due to initial rise in testosterone. Remember, these luteinizing hormone agonists, once they are taken away, I mean they are brought, they may lead to the initial increase of testosterone. They might also worsen the symptoms initially, and the other side effect is that they are costly to be used. Next slide. So that is it about my presentation, but I thought I would not leave. I had added a slide as far as how do we prevent prostate cancer. So one of the ways to prevent prostate cancer is actually to do early screening, especially in our setting. We know that Black males have a high, they are highly predisposed to development of prostate cancer. So we should encourage our males to do early screening. And by early screening, they should go for a PSA and digital rectal exam combined. And once it is elevated in one value alone may not be enough. The other thing, as far as prevention is concerned, is the lifestyle modifications. We encourage them we encourage them in their diet to have mainly vegetables and fruits. We encourage them to be active. Those who are smokers, we discourage discourage them from smoking, they should stop. And those who are taking alcohol should take it in moderation. And also exercise is another thing that can help in the prevention. So I end my presentation by saying we can be vigilant and live healthy. So you don't need to give up. This disease can be conquered. I thank you very much.